Good, man. What's going on? Good. You got chairman's name? Oh, he's already got one. Wait a minute. Double.
Ms. Grace, you want me to pass out maybe?
Excuse me, chairmanship. Trying to call it out. Okay, well.
Okay, I think we have a quorum, and we'll transact business in just a second when we take roll. But first, members, the clerk is noticing that not everybody is logged in for their microphone. So if you would log in your code, I believe it is your district number plus 4 zeros, especially for Senate members. We don't have this technology in the Senate, so if you would punch in your district number and 4 zeros. With that, we will take the roll. It's a joint committee, so we'll do it by House. So we'll start with the Senate, and then we'll take a roll of the House. So Madam Clerk of the Senate, if you would, please take the roll.
Is present Senator Lamar? Is present Senator Watson? Is present Senator Yeager? Is present Chairman Stevens?
Here.
Is present, Mr. Chairman, you have 5 Senate.
5 members present. If the Clerk of the House would take the roll.
Representative Camper, Representative Faison, Representative Garrett, Representative Miller, Representative Moody,
Here.
Representative Sparks, Representative Williams, Representative Zachary, Chairman Halsey. You have a quorum of the House.
We have all members present. Welcome to the audience. We have a full crowd here today for the Joint Committee on Ways and Means review of the application from the administration for the Rural Health Transformation Program grant. This, as you may know, this grant program was as a result of the $50 billion funded by the Trump administration and Congress in the One Big Beautiful Bill. And Tennessee had an opportunity to prepare a plan, which has been submitted to the Trump administration. Today, we will hear from the Lee administration regarding that plan, the award by the Trump administration as based on that plan, and consider the approval of the acceptance of the grant amount of the first tranche of grant funding. Speaking for the committee, we intend to have additional meetings in the future to consider the acceptance of approval of additional awards in out years. With that, if the department would go ahead and the other presenters would come forward, and as they're moving forward, members, please take note of questions you have as they are going through their presentation. I will interrupt them periodically, as it seems like I think we have members wanting to make questions. We'll interrupt them, so be prepared for questions if we interrupt. But I do want to try to get through the entire presentation and let you do the whole thing, but we will interrupt some for questions. But members, please, if you do have questions, just make note of them, and we will, and then we will let those give you an opportunity to ask those questions. And with that, everybody, you know the drill. If you would, please introduce yourself, what department or agency you work for, and then you are recognized. So I don't know who's going to go first, but go ahead.
Yes, sir. Yes, sir. Thank you, Mr. Chairman. John Webb, Chief of Staff and Deputy Commissioner for the Tennessee Department of Health. Chairs and members of the committee, thank you so much for the opportunity to appear before you today to discuss an exciting opportunity for the state of Tennessee. We appreciate the committee working us in so quickly to discuss this grant opportunity, and also want to say a special thank you to the committee staff and legislative staff. As you know, the grant notification process is relatively new to agencies, and your staff has made it a seamless transition for us. So wanted to say thank you for that. The Tennessee Department of Health respectfully requests the committee's approval to accept almost $207 million in federal funding associated with the Rural Health Transformation Program, which is administered by the Centers for Medicare and Medicaid Services. And as Chairman Stevens said, this represents the first year of funding. While TDH is the agency requesting the approval to accept the funds, this award reflects a broader multi-agency effort to secure resources to help improve health outcomes for Tennesseans statewide, particularly in rural communities. We're joined today by representatives from partner agencies involved in that work, including the Governor's Office with Michael Hendricks from the Policy Office, J.W. Randolph, who works with me at Health. He's the Deputy Commissioner for Public Health Infrastructure. And then in the audience, we have Dr. Victor Wu from TennCare, the Chief Medical Officer there, and then Matt Yancey, Deputy Commissioner for Behavioral Community Programs at Mental Health and Substance Abuse Services. Now, this is a lot of money. There are a lot of programs. I know you've got a lot of questions. And given the scale of that award, and its potential impact, Mr. Chairman, we have a presentation we'd love to walk through and kind of hopefully answer some of your questions and give you an idea of how we plan to program the money. And with that, I'll turn it over to Michael.
I'm Michael Hendricks, Policy Director for Governor Bill Lee. It's an honor to be with you, Chairman, members of the committee. I wanted to kick things off today and before handing it over to my colleague and our other colleagues for additional questions you may have. But it's really an honor again to be with you. On December 29th of last year, Tennessee received notification that we've been awarded more than $200 million in the first year of the Federal Rural Health Transformation Program, with the potential to receive approximately $1 billion over the next 5 years. This is, by some measures, the single largest investment in rural health in Tennessee history, and more than we requested. I believe a sign of the strength of the application that this state and this administration and our partners here have been able to put together, and our commitment, a shared commitment to rural health. As Governor Lee has said, what happens in rural Tennessee matters to all Tennesseans. And the governor is grateful to the Trump administration for creating this historic opportunity to transform health outcomes across our state. Tennessee was ready for this moment. It was ready for this moment because rural health has been a priority of this General Assembly and this administration since day one. From this governor's very first executive order, directing every agency to strengthen its impact on rural Tennessee, to the creation of the Rural Health Task Force, to investing hundreds of millions of dollars of TennCare shared savings through the Healthcare Resiliency Program and more initiatives. We built a foundation together that positions Tennessee to put these federal dollars to work immediately and effectively. Our vision, which guides the application, and you'll hear more about from my colleagues, is straightforward. Better care closer to home. We envision a system of care that honors the strength and independence of our small towns, while also providing critical and urgently needed investments and connecting them to trusted partnerships, modern technology, and a shared purpose. As you'll hear more about, Tennessee's plan is organized around 5 focus areas that align with CMS's priorities and build on proven Tennessee models and what we need as a state. First, rural healthcare transformation. That's the first pillar. Rural healthcare transformation to strengthen hospitals and expand services. Second, maternal and child health to give every Tennessee family a strong start. Third, technology infrastructure to connect rural providers to modern tools. Fourth, community prevention efforts to, as we call it, make rural Tennessee healthy again. And fifth, workforce development to build the pipeline of providers our communities need. The funding structure provides Tennessee with $100 million in guaranteed baseline funding each year, with additional competitive dollars awarded based on the strength of our application and our commitment to meaningful reform. My colleagues will walk you through the details of how these dollars will be deployed across Tennessee's rural communities. And I should note that our continued eligibility for these funds and the potential for even more resources depends on Tennessee taking action and delivering real results. That's one reason among many. We are thankful and grateful for the ongoing partnership and leadership of this General Assembly and the members of this committee to strengthening rural Tennessee. This administration is ready to move quickly to deliver on our promise of better care closer to home. And with that, I'll turn it over to my colleague, JW, to present further details on Tennessee's Rural Health Transformation Program. Thank you.
Thank you, Michael. Thank you, members. J.W. Randolph, Deputy Commissioner for Population Health Infrastructure at the Department of Health. And Chairman and members of the committee, thank you all for the opportunity to present today. It's an honor to discuss these investments in rural health. I also want to share my gratitude for the fact that this application was put together through a highly collaborative process. To meet the goals set out by CMS took a lot of different types of expertise, and I'm very grateful for the partnership provided by the Governor's Office and our partner agencies. The Rural Health Transformation Fund supports Tennessee's participation in CMS Rural Health Transformation Program, established by H.R. 1, the One Big Beautiful Bill Act of 2025. All 50 states were eligible and did apply to receive roughly $1 billion each in installments of roughly $200 million for 5 years. As Michael mentioned, CMS is structuring the funding into two components for each state. Baseline funding, which is a guaranteed $100 million per year for each state, and a competitive funding component of roughly $100 million awarded based on demographics and evaluation of each state's plan and alignment with federal strategic goals. We're pleased to report that all 50 states, including Tennessee, requested $200 million for budget period 1 in rural health investments, but were ultimately awarded nearly $207 million by CMS, outcompeting most other states based on our alignment with CMS goals, the quality of our application, and building on the commitment from Governor Lee and this body to investments in rural health. CMS expects these dollars to support system-level transformation, not ongoing operations. So each initiative included in Tennessee's plan was required to identify key performance metrics, a phased implementation timeline, and a year 6 plan, describing how successful efforts could be sustained or scaled without additional state investment beyond the performance period of RHTP. This approach builds on Tennessee's longstanding rural health strategy, including the Rural Health Task Force, Governor Lee's Executive Order No. 1, and prior investments in community-based and provider-led solutions by this body. Importantly, no state match is required. CMS, as Michael mentioned, places significant emphasis on timely and effective deployment of RHTP funds. So while these funds may be expended through the federal fiscal year following the year in which the funding is received, the first budget period provides a relatively short window for us to demonstrate progress. CMS has made clear that the allotment of future RHTP funds are informed by a state's demonstrated ability to initiate implementation and responsibly deploy early funds. For that reason, there's a strong incentive to move efficiently in year 1 while maintaining appropriate controls and exercising the fiscal responsibility that is Tennessee's hallmark. Our approach reflects this balance, prioritizing initiatives that build on proven models, such as the Competitive Healthcare Resiliency Program, phasing more complex initiatives to allow for proper procurement, oversight, and performance monitoring, and leveraging partnerships established through existing rural health initiatives, including work with our county health councils, the Safety Net, and the statewide EMS network. This strategy allows Tennessee to demonstrate early momentum while maintaining fiscal discipline and federal compliance. CMS required states to address at least 3 eligible uses from this list in green. Our plan addresses each area with a focus on expanding access to care in rural and underserved areas, supporting innovative and value-based care models, strengthening workforce recruitment and retention, improving data technology and care coordination, and addressing community-level drivers of health. All proposed use of RHTF funds fall within these eligibility categories. This funding is not being used to support ongoing operations or to create new recurring obligations. As I said, each initiative includes defined metrics and milestone consistent with CMS requirements and state oversight expectations. I will note that ineligible expenses included construction and some restrictions on provider payments, clinician salaries, and loan repayment.
If I could, just,
Yes, sir.
I'm gonna pause right there and open it up and see if there's any members who have questions on what they've heard so far. And we want to, again, I want to try to limit that to, relevant to what we heard so far. We can get into other things later. Representative Williams, you're recognized.
Thank you, Chairman. Thank you, gentlemen, for being here today. I just had a pretty simple question. Define rural.
Okay.
So thank you for that question. So CMS uses a HRSA definition of rural. In this opportunity, they're not particularly prescriptive when it comes to the defining the definition of rural, but refer us back to both HRSA and OMB definitions, looking at non-metropolitan counties. That's an OMB definition. Outlying metropolitan counties with no population from an urban area of more than 50,000, or specific census tracts that meet the rural urban commuting area or the RUCA population density or other qualifying criteria indicating rural characteristics. And so for the purposes of this plan, initiatives will focus on these HRSA-defined rural areas to ensure alignment with CMS expectations. Projects can include neighboring non-rural areas if they significantly impact rural health outcomes or service delivery.
Thank you. Just to follow up there, how does that federal designation you just referenced compare to what we determine as rural?
Yeah, happy to pass that one to you, Michael.
Well, it's very important if we're going to spend $1 billion that we understand what rural is.
Yes, sir. Happy to. At the department, for instance, I think we use one definition of rural where we have 89 rural counties and 6 metro counties that we partner very closely with. We've used that definition in the past, but this is a constant conversation around rural health, as you know, is the right way to target those rural populations.
Yeah, the only place I could really find rural is clearly defined in the application process was on page 6. And it describes what 15 critical access hospitals, 2 rural emergency hospitals, 326 health clinics, 100 rural FQHCs, 42 small hospitals. It did reference that 16 rural hospitals closed. So we know what a rural hospital closed. We know 16 of them closed. It says that there's only 6 remaining. So I guess my question is, do you believe the proposal that you presented to the government, the federal government, and to us here today serves rurals? Or is it more weighted towards other things?
Yes, sir. I think to satisfy the expectations of CMS is absolutely geared towards making sure that these funds support rural populations.
Thank you.
I'll just add, we firmly believe that this is a transformational investment for rural Tennessee. And whether it's a federal definition or our definition, these dollars absolutely flow to those areas.
Yes, Mr. Hendricks, but I would also say that the federal government, when they ask for their money back, are going to want to know what rural is as we define it, as well as what they define it and how they mesh together. Because by taking the money, we adopt whatever it is we've defined or they've defined in the application. And it's simply not there. Thank you.
Chairman Halsey.
Thank you, Mr. Chairman, and thank you, folks, for being here today. When you said this money won't be used to go to cover ongoing programs or operations, there was a couple of things I was really worried about. One of them was I didn't think this money should be used to cover hospital operating deficits that already exist or pay down historical debt. When you made that statement, are my fears alleviated?
Yes, sir. That would not be an eligible expense for these funds.
If you would, please go ahead and continue on with your presentation. Thank you.
Thank you, Chairman. The RHTB NOFO identifies 5 strategic goals that states are required to address. These goals from CMS, represented in the circles on this slide, include sustainable access, innovative care, tech innovation, making rural America healthy again, and workforce development. Tennessee has organized our investments so that each major focus area corresponds directly to one of these CMS strategic goals. Rural health transformation for sustainable access, maternal and child health for innovative care, technology infrastructure, making rural Tennessee healthy again, and workforce development. This structure mirrors and builds on the strategic direction established through the Rural Healthcare Task Force, emphasizing access, prevention, and workforce development. Through the following slides, we'll describe each strategic goal and Tennessee's aligned focus areas. First is rural health transformation or sustainable access. CMS describes this goal as supporting rural health innovations and new access points that promote prevention and address the root causes of poor health outcomes. We will do that through competitive programs to expand integrated primary behavioral and specialty care access across rural Tennessee by increasing the number of clinics offering co-located services and connected referral systems. Support for emergency medical services and community-based teams, including a new ambulance for each county and specialty training for EMS providers. Optimizing the balance of care in rural communities, including an expansion of the existing safety net that will invite new sites and services for rural health clinics. establishing a memory care assessment network that will provide support for those in rural areas needing assessment and treatment for Alzheimer's disease and related dementias, including navigation supports for those patients and their caregivers in all rural communities. And capacity building, including investments in training for behavioral health workforce, certification of community health workers, and a partial extension of the very successful dental pilot program into a 6th and 7th year. These initiatives build on Tennessee's emphasis on locally driven solutions and prior rural access initiatives. Next, I'd like to talk about innovative care or maternal and child health programs. CMS's innovative care goal emphasizes new care and payment models that improve outcomes and shift care to appropriate, cost-effective settings. Given Tennessee's opportunities for improvement in the areas of maternal and child health, we're meeting this goal through competitive programs to leverage Tennessee's Maternal Health Strategic Plan and Tennessee's Infant Health Strategic Plan, strengthening workforce and digital infrastructure around maternal and child care supports, direct investments in the regional perinatal centers, investments that will allow our fetal and infant mortality review team to serve rural areas more comprehensively, and a $100 million expansion of value-based payments for hospitals, as well as maternity and dental care led by our partners at TennCare. These efforts build on Tennessee's existing work in healthcare resilience and care innovation, expanding access to comprehensive maternity care in all Tennessee maternity care desert counties, and improving perinatal quality outcomes. Success measures will include 100% of maternity care desert counties served, postpartum depression screening increased to 91%, and postpartum visit attendance increased to 94%.
I'm going to pause right there. I'm going
Yes,
to
sir.
try to take two of these at a time.
Yes, sir.
And I think we have one, the math doesn't work out, but anyway, the last one will be a single. So I just want to open up for questions on the first two sections we heard there. If anybody has questions about those first two. Senator Lamar, you're recognized.
Thank you, Mr. Chair. So I want to ask questions about your focus area on maternal and child health, seeing that is one of the main components of your application to be awarded with this funding, which I'm glad about. Maternal health is very important to me. So I wanted to know, can you go into more detail about these two initiatives that are geared towards maternal health? What specifically will they be doing? Also, will these programs that are being implemented, are they going to be pilot programs? Are there going to be reoccurring programs? In these areas, since this is talking about a short-term grant from the federal government. And in addition to, you talked about TennCare has now $100 million to invest in maternal value-based payments. So essentially, would they be able to add doula services to one of the services that they can offer and have the money to pay for that?
Thank you, Senator. We have posted our application publicly, which will go into greater detail for each of these initiatives. I can speak to them briefly, but we'd be happy to get with you to speak with them in more detail. The Rural Fetal Infant Mortality Review, my understanding is this is an expansion of services that are available in many metropolitan counties that will serve meeting the goals of the Maternity Care Strategic Plan and the Child Care Strategic Plan in those rural communities. But it is an expansion of services to communities that have not necessarily received those before. With the competitive maternal and child health healthcare resiliency program grants, those we intend to be received by those organizations providing maternal and child care services. Historically, we've preferred to be flexible and let local providers and communities be the ones who are setting the direction for their applications. We don't think it works very well when we are prescriptive. That's been extremely well received through the federal healthcare resiliency program, as well as the healthcare resiliency program for rural communities that was funded through the shared savings program. Those have historically been 5-year commitments that we've run both through the federal and state programs. As far as the value-based payment programs, that's probably a better question for our colleagues at TennCare, and I'd invite Dr. Wu to speak to that if you'd like to.
Thank you, Dr. Brew. Go ahead and introduce yourself and who you're with.
Absolutely. My name is Victor Wu, the Chief Medical Officer at TennCare. Senator Lamar, members of the committee, again, just want to echo our colleagues' thanks and for the opportunity to come and speak about this really exciting opportunity. Senator Lamar, to your specific question, you asked about the value-based payment program. As JW mentioned, we have $100 million allocated that TennCare will be responsible for using to support, but it is across 3 different areas. So I wanted to make sure that was clear, that it is inclusive of maternal health and child health, but it's also inclusive of dental care in the rural areas, as well as rural hospitals and the work that they're doing, which are all critically important. Specifically to your question, as we think about maternal and child health, we know that our moms and families in rural areas face challenges in access. And so we're really focused on supporting value-based, outcomes-based approaches to helping our primary obstetric providers in those communities. They may be family practice providers, family practice or OB providers, and really creating the right infrastructure to allow them to have more access to resources, getting more moms early in the pregnancy in. And those practice clinics may choose to partner with doulas, may choose to partner with other types of additional supports, which include community health workers, but we're really focusing on increasing access through the kind of the obstetric network, which is kind of the hallmark and bread and butter of TennCare maternal health care and payment.
Thank you. Representative Williams.
Thank you, Dr. Wu. Thank you for coming. Just had a quick question about the one of the slides previously was about reimbursement rates. They were in the column of green. I just wondered, in this $100 million that your department be responsible for, let me say what we've done in maternal health and infant mortality is pretty amazing over the last 5 years. I've been here for 15 years, and it's great to see what we've done. The question is since provider reimbursement rates are a part of the component, do you expect in rural hospitals that those that are providing TennCare services could expect to see a higher reimbursement rate that more is in line with what our metropolitan areas would get from TennCare?
Thank you for the question. In terms of the reimbursement rate itself, is actually one of the areas, as JW mentioned earlier, that CMS was very clear on, that the dollars that we are receiving through the Rural Health Transformation Funding cannot be used to increase rates because it's not part of the, I think, the sustainability of the program. This is non-recurring funding. However, we are thinking about how can we support rural providers, meeting some of the challenges. We know that expenses in rural communities look different than they do in metropolitan areas. And so as we think about the value-based payment approach, we really believe that the funds can be used to drive better health outcomes and paying for those types of services, whether it's infrastructure, whether it's around the way that they serve members that are TennCare, will result in more dollars going to those rural providers, but it won't be going through a provider rate increase.
Okay. The reason for the question is I can have a physician, orthopedic surgeon can move to Cookeville from Memphis, and he's already getting 73% a difference and 73% of what he got in Memphis, but it's the same TennCare patient. So that's what I'm saying is you're not increasing provider rates, you're actually paying the rurals the same thing that you would pay in metropolitan areas. So it's not increasing the rate, it's the reimbursement is more in line with what it costs in other areas because it's harder to deliver healthcare in a rural part of the state.
Appreciate that perspective. And certainly we're going to do the best that we can, but within the parameters of the fund.
Chairman Crow.
Thank you. Following up on that, have you guys had discussions with the federal government relative to the wage index? That's part of the problem we have is, I guess, in especially the rural areas of Tennessee, the wage index and those sorts of things to help with reimbursement a little bit. I don't know. It's been tough through the years to get that changed. Is there any work on that? You know.
Thanks for the question. One of the things I think, happy to continue these conversations. I know every year that we have a great opportunity for TennCare to talk about our provider rates, and I think there will be lots of forums for that to come in other legislative hearings. And a lot of thanks to the legislature and this committee, joint committee, especially on some of the most significant increases in hospital rates that we've seen in a long time. As respect to the Rural Health Transformation Fund, though, the focus of it is really, I think, clear from the federal administration that the goal of the funding is for transformative new work and not for it to become a additional dollar that fits into either provider rates or ongoing existing places. And so I think while happy to have those conversations, it's not an area that we are focusing on as it pertains to the rural health transformation, just because, again, of the parameters that have been set at the federal level.
Yeah, thank you. I appreciate that. Probably wrong place to ask it, but thank you.
With that, if you want to continue on to your next slide and the rest of your presentation.
Thank you, Chairman. Next, we're going to talk about technology infrastructure. So CMS identifies technology as a foundational piece of rural health transformation into the future of rural medicine. Tennessee's technology investments include competitive grants for health tech infrastructure, establishing a health information exchange across Tennessee, expanding Tennessee's Community Compass closed-loop referral system, and supporting rural provider adoption of interoperable solutions through Novel Rural Health Innovation Catalyst program. These initiatives extend the state's ongoing modernization efforts. Success metrics will include a structured data exchange at 85% of encounters, 500 providers enrolled in the Health Information Exchange, and 200,000 annual referrals from Tennessee Community Compass. The next goal is making rural Tennessee healthy again. So the saying goes, it's easier to build strong children than to repair broken men, or an ounce of prevention is worth a pound of cure. But whether you work in our department or TennCare or the Department of Mental Health, we're always working to establish upstream solutions for our health problems. So this can be thought of as our prevention bucket, which addresses the factors outside of clinics where people live, work, play, and worship. These initiatives include competitive grants focused on health prevention, similar to the Rural Healthcare Resiliency Program the governor and legislature have funded through TennCare shared savings programs in the past. Community grant programs to support active living and nutrition security. Investments in support for county health councils, groups of local volunteers existing in every county in Tennessee who will inform and engage with these initiatives at the community level. And a competitive opportunity to establish a statewide non-emergency transportation program. These investments align with Tennessee's community-based approach to improving health outcomes, and success metrics will include funding that touches at least 89 of Tennessee's rural counties and awardees that are better connected to and informed by local expertise in their community. And happy to pause there, Chairman, if you'd like.
Yeah, any questions? Yeah, Chairman Yeager.
Thank you, Mr. Chairman. I do have a question regarding grants. I would like to know if there are limitations on who can apply for the funding. For example, could a private vendor be able to apply to the state directly for funding for one of these community grants, for example, or would the entity need to be attached to a hospital or a municipality?
Thank you for the question, sir. In the past, we've said if you are an entity with the state, then you are eligible to apply. So that includes hospitals or private vendors, but any type of organization is eligible. We want this competitive pool to be large and for the best ideas to come to the top.
Thank you. Thank you, Mr. Chairman.
Yep, Representative Williams.
You can ignore them if you want to, Chairman.
I looked to my right first. But
No, it's fine. Gentlemen, I don't know who really wants to answer this question. It's about the statewide health information exchange. I did a little research on, this is not new to the state. We've attempted this in fiscal year 15-16. This body appropriated $7.4 million for information exchange programs. The following year, we doubled down on it and added 24 new positions, adding $14.6 million to information exchange. Didn't seem to work very well based upon my research there. It was attempted again to add $15 million in the 2021 fiscal year for information exchange, which this body did not fund because of the lack of success of the other two. I guess my question is, when you look at this new $30 million we're wanting to invest in a statewide healthcare information exchange, why is it going to work this time? And what did we learn from it not working before?
Chairman Williams, great points, and we were well aware of the history of the HIE. One thing that we've done to be a little more deliberative about it is we hired a consultant last year to kind of help us map out possible paths. So I think, when in the previous iterations, we kind of had the state had their mind set up for one thing. What we've done is we've got a vendor to kind of give us 2 or 3 paths to look at and evaluate. We're not going to jump into anything in year one. We're going to continue that evaluation process. So we're going to be very deliberative. I think there are a lot of lessons learned. We've been very intentional to engage people that participated in the other attempts. There's a lot of institutional knowledge in that. And so we're hoping to learn those lessons and kind of work with our vendor to kind of get a different path set forward.
Did we utilize a vendor the last time we did it, or did we try to do it internally since we had a 24 position?
I know that at one point we did it internally, but that predates me a little bit. And so this is the path that we're taking right now.
Is the vendor of desire, I guess you could say right now, is that vendor of desire any part involved in what we've previously done?
Not that I'm aware of. I could double check for you.
Thank you.
Representative Camper.
Thank you, Mr. Chairman. You mentioned hospitals being able to access the funds. Well, Chairman, thank you for mentioning this earlier, that was so many hospitals have closed in the rural areas. And a lot of those patients are coming to urban areas to be seen. So will the hospitals that are servicing these people now, until you stand up rural hospitals, be able to access these funds until the transition to I imagine maybe new hospitals will be built, or we will do something with the old hospital and make it transformative? How will hospitals that are now serving this community be able to access these funds?
Thank you very much for the question. Through both the federal program and the state rural program, we've had the opportunity to stand up entirely new rural hospitals, including in at-risk and distressed counties, which has been incredible to see the transformation in those communities that right-sizing the hospital has brought. I think we're trying to bring those lessons here to this program. So through our collaboration, both with those rural hospitals as well as the partners in the metro counties.
Could you expand on that second part? You said in the metro county.
Yes, Representative. So in the federal program, that was available for all 95 counties, including metros. In the rural program, it was the 89 rural counties from the Department of Health's rural counties.
So if I'm servicing them based on their zip code, they live in a rural area, they do not have access to a hospital right now today. They're being serviced by some of these urban hospitals. Until you stand these other hospitals up and they continue to come to these areas, will these hospitals be able to access those funds until the transition is complete? I understand you can stand them up quick. Hey, I get it. But until that happens and someone needs to go to a hospital, they need to be served, and their zip code is in a rural area, in this transformative area, will they be able to receive funds for those patients that they see? That's what I'm trying to get an appreciation for.
Yes, ma'am. If I understand your question correctly, we want, as it mentioned to Chairman Williams, we want those folks in those rural communities to be able to be served by these funds as well as those providers.
Okay. All right. I think I got that. Secondly, one more, Mr. Chair. So the state has spent money over the years investing in a rural doctor program with Meharry, MTSU, and sending doctors into these areas. Will they be able to access any of these funds to keep that going until, this is a 5-year program, so until everything get up and running, I mean, we still would like these doctors to go there. Will they be able to access any of these funds?
Yeah, thank you for the question, Representative. Yes, and the workforce development piece will be the final slide that I'll touch on. But we're really proud of the placements that have happened through our Tennessee Student Loan Repayment Program, as well as the dental program that's been so well supported by this body.
Okay, thank you, Mr. Chair.
Thank you, ma'am.
Chairman Yeager.
Thank you, Mr. Speaker. Mr. Chairman, I have a follow-up question for you, sir. When you were talking about I had a little difficulty hearing you, which I'm sure is my fault, but you talked about standing up hospitals. Explain that phrase to me, just exactly what you mean by that. Are you literally talking about hospital construction or getting?
Yes, sir.
Help me out.
Through the federal ARPA dollars funded a healthcare resiliency program that the Department of Health was proud to support. One instance is in Hardeman County in Bolivar. That hospital has moved to a new footprint and right-sized so that it's going to be a better fit for that community. That's been something the department's been really proud to support and see happen in one of our at-risk and distressed counties.
Mr. Chairman, can I follow? Well, but that was ARPA funds. We're talking about these rural funds now. Would you be able to do the same thing with these grant dollars?
So construction is an ineligible cost.
Thank you.
Yes, sir. Construction is an ineligible cost. Yes, Representative.
I didn't.
If I think we have one slide to go, so if you want to.
Yes, sir. Thank you, Chairman.
There we go. There we go.
Thank you. So yeah, construction, provider payments, some clinician salaries, intergovernmental transfers, and some EMR replacements were ineligible expenses.
I think you have, if you would, let them finish up with they have one slide to go in their presentation, and then we'll open up for a free-for-all type questions. But if you would, just go ahead and finish up with your last slide.
Thank you, Chairman, and thank you, members, for the conversation. We're going to end with workforce development. So CMS emphasizes workforce development as critical to sustaining rural healthcare systems, expanding our rural health workforce pipeline by increasing residencies, apprenticeships, and internships that establish sustained training and placement capacity statewide is a priority of this application. So we're working closely with our partners at the Department of Labor and Workforce Development, TennCare, Mental Health and Substance Abuse Services, and the Rural Center of Excellence to establish comprehensive workforce pipelines, including MD, DO, and psychiatry residency programs, behavioral health career pathways, recruitment and retention incentives, investments in academic health department partnerships, which include our academic partners from across the state. In summary, our proposed use of rural health transformation funding reflects successful maneuvering through a competitive federal award process, recognized by a higher award from CMS than was initially applied for, requires no state match, builds on Tennessee's established rural health strategy that will go to many of our most underserved and rural areas, includes defined metrics, phased implementation, and long-term sustainability planning, maintains fiscal responsibility and accountability in collaboration with our federal partners. And so we're requesting the committee's approval to proceed so implementation can move forward in a timely and coordinated manner. Thank you, Chair. Thank you, members. And we look forward to questions.
Thank you for your presentation. Now, members, we do have time for some discussion and questions. Chairman Halsey, I believe you had a question. You're recognized.
Thank you, Mr. Chairman, and I appreciate that. I have two questions, and the first one, I was reading your application to the federal government for this money, and it says Tennessee will introduce and pass legislation to eliminate certificate of needs across facility categories in 26th legislative session. The elimination of CON will reduce barriers to entry for new providers, which will help facilitate greater access, lower costs, and improve quality of care, which I agree with that, and ran a bill 2 years ago to do that and couldn't get out of the first committee. Implementation will occur by January 1st, 2027. So my question is there a bill in the pipeline, and how are you so sure that the legislature is going to pass it? Because I've seen them bow up, more than one time on the floor. And if it does not pass, how does that affect the outcome of next year's money? Were you to apply again? And is there a matrix to figure that out? The second question is, are there any policy changes that the health department has to do that are strings attached to this money?
I'll jump in on the first question, then turn over to my colleagues in the Department of Health. To be clear, no specific legislation has been filed yet, but you are correct. In our application, we did mention policy items. What we committed in the application for Tennessee was expanding rural access, removing barriers to offering better care closer to home. So that's really what you see. And I think how we approached it was really working backwards from what do families need to keep their kids healthy, or what works for small businesses trying to keep their employees healthy, and also responding to what the Trump administration and Dr. Oz has been saying. the guidance to states was to reimagine, to change the way we envision rural healthcare in America, to not just pay the bills, but address root causes and to make things better. So CMS will be evaluating, to your question, they will be evaluating whether states, including Tennessee, follow through in their commitments, whether it's funding or policy. The governor supports these items because he believes they're good policy for Tennessee, not just for federal dollars. But CMS has said that they will reevaluate states in subsequent years to, again, see, are they delivering results? Are they passing policies, proposals that will make the whole environment for rural healthcare better? And will reevaluate. They've not provided a specific rubric to say how much funds we could get in addition from passing those policies or implementing policy change or reforms, or how much we may lose out on in subsequent years. But that is the guidance that they've provided to us. Yeah.
For my own, before I recognize somebody else, when you say lose out on, it is your understanding that if you fail to meet a policy goal that you said you would meet, you would lose out on additional money in the future, or could they claw back money because you failed to meet a promise you made?
Both.
Okay.
So just to be clear, so the federal government structured this as an invitation, not a requirement to states, an invitation to reform, and said, we will provide more support for you as a state if you show that kind of commitment. And they have indicated that we as a state would be more competitive for more funding through policy change, and that some share of this year's funding, if policies are not implemented, might be clawed back. Again, they've not provided us details on what that might look like.
Oh, Representative Garrett. Thank you, sir.
Thank you, Mr. Chairman. Thank you all very much for your presentation. I've been listening to you all, listening to some of the questions about how much money's coming in and where it's going to be spent. And obviously the money can be used for certain things and the money can be used for not for certain things. So my question revolves around really compliance. In light of some of the things that have been happening with our neighboring states, specifically in Minnesota, where we have billions and billions of dollars that's been wasted for fraud, probably intentionally up there. I'm just kind of wondering what type of compliance and oversight that you are prepared for to make sure these funds that are spent appropriately, so we don't have these clawback issues that some of the members are concerned about. This money going back and not being used for proper purposes. So what type of compliance and oversight are we looking at with this fund?
Yes, sir, Representative Garrett. We have our typical standard compliance that we do now, where we work with the federal government on many different grants. We have a structure in place. We kind of enhanced that structure with the influx of ARPA money. We kind of set up a different path for us to attract funding, and that included hiring a third-party vendor to assist us with that compliance. And the goal would be to help us filter what a good grant looks like before it goes out the door, what kind of language we need, what kind of monitoring we need on the front end. We're going to put in some pre-screening for invoices and applications on the front end. That's something that we did not do under ARPA. We think there's some benefit in getting things aligned before it gets into a payment process. That'll be good for the grantees and for us to make sure everybody's still in good shape. And then, of course, on the back end, we'll have our internal compliance that'll look at that based on a risk assessment like we normally do with the comptroller's office. And then our third-party vendor will also provide us some spot audit and check. So we're trying to triple layer that because that's one of our biggest concerns as well.
Great. Thank you all very much for that. Appreciate it. Thank you, Mr. Chairman.
Chairman Watson.
Thank you, Mr. Chairman. I have a number of questions, if you don't mind, that I think the Senate will be interested in hearing. So if they indulge me. The House will be interested, but particularly the Senate. Of the $207 million, $100 million of it is a base amount, so that we will get the $100 million regardless of what happens in the other spaces, correct? Right. Okay.
Yes, sir.
Okay. And then I think you responded to the next question I have, which is in the competitive component, which is the other 107 million, that money, the amount every year could go up or go down depending upon the evaluation by the feds on what we are doing, correct?
Yes, sir.
And in the first year is the expectation that, what is the execution date? Like when would we receive the 207 million? Is there an execution date?
So our final step with CMS is to submit a final revised budget with the additional funding, of course, permission from this body and a budget expansion. At that point, we would be free to begin spending these funds.
And the first year's tranche of spending, if I understand this graph correctly, would have to be fully completed by September 30th, 2027?
Yes, sir.
And in the event that all 207 million is not expended, is there a carryover provision or do we return the balance back to the federal government?
CMS has been pretty clear that they're happy to claw the money back.
Well, I'm not asking if they're clawing it back. I'm asking, are we allowed to carry it forward? We're not allowed to carry it forward. So if we can only spend 200 million, I guess my point, Mr. Chairman, here is that we have to be careful that we don't do wasteful spending just because we need to spend all the money that's in the bucket.
Yes, sir.
Okay. What are the components that are in the base funding? Much of what you've talked about is seems to me in the testimony seems to be on the competitive side of the funding. What's in the base funding?
Chairman, are you referring to this particular graph from CMS?
Right. I mean, 100 million is guaranteed. So what is included? And then you broke out different aspects of it for different amounts of money. What of that amount is in the base funding versus what's in the competitive?
I understand your question, sir. Thank you. It's one tranche of money. We receive it as one bucket, one tranche to be spent from with no difference between baseload and the baseline and the workload funding.
So with that explanation, is conceivable that we could be doing something that's funded by the competitive funding. We lose competitive funding. We wouldn't, even though it's not part of the competitive fund, and then we would not be able to continue that component, correct?
That's correct.
Okay. I think members need to be aware of that. Now the hard question. You've used, and you've reused it multiple times, and you use it in the definition, and it's transformational. So far, I have not heard anything that's transformational. I think the challenge that the CMS has given to us is to actually be transformational and not simply put additional resources into existing delivery systems. For those who've been around me, here in the legislature, you will know that if we continue to just fund the same delivery system that we have, we will end up in the same place that we're in. If you want to look at a current day example, it would be the Affordable Care Act. Tennessee chose not to expand Medicaid because we figured at the end of the day, we were going to end up in the same place that we started. And guess what? We're in the same place that we started because it wasn't really transformational, and we realized that. So I think listening to some of the discussion here, I didn't hear anything that's actually transformational in the delivery system of healthcare. I kind of heard, hey, we're going to have more additional dollars to put into systems that we already have in place. Not for you to answer today, but I think for me to be supportive of this, that's going to be a key component of that, because I'm just not interested in putting more money into a system that we all recognize here is not delivering in the rural areas of the state. And a failure to, because even amongst the members' questions, most of their questions were, is this going to give more money to systems that I already have in place in my community? They didn't ask a question about, is this a new system in my community? Is this going to change something in my community? They wanted to know, hey, I've got a hospital here in Memphis, and I want to know, am I going to get more money for the hospital in Memphis? Not how am I transforming the care that's being delivered to those folks? It's just, am I going to get more money? And that's not the right question. The question is, how are we transforming the delivery system? Sorry for the lecture. A couple other, and then I'll be done, Mr. Chairman. Thank you for the indulgence. With the elimination of certificate of need, is that a global elimination that you're going to be proposing? Because there are pieces, you responded that there is no legislation introduced. Well, there are actually multiple bills that have been introduced by the legislature that deal with certificate of need. So is your proposal, should we anticipate that your proposal is a global elimination of certificate of need upon all the different areas, or is it more targeted towards certificate of need elimination in these specific areas?
Thank you, sir. Thank you for that question. You're absolutely correct that this General Assembly has proposed reforms and passed reforms for items like certificate of need over many years and continues to trend in that direction. Our intent as we study that past is to look to the future and build on that work. As it relates to scope of practice, the areas that CMS in particular looks at are nurse practitioners, physician's assistants, dental hygienists, and pharmacists, and ask the question, how can we enable skilled, credentialed providers to practice who are in these rural communities to practice at the top of their license? And as Dr. Oz has noted, this is an urgent need. And we have these folks serving rural communities today. So as this administration looks to legislation, we're looking at those 4 practice areas in particular.
And I'm just about done, Mr. Chairman. The committee's been very kind to allow me this much time. In the elimination of certificate of need, or in the elimination, or the reformation of our scope of practice, is there a cost to the state associated with that, or are there cost savings associated with that?
So at this moment, I do not have firm fiscal notes for any legislation that we're drafting at this moment, but I can say we don't anticipate large fiscal notes for something that we believe will ultimately save Tennessee and Tennesseans money and deliver better care over time. And so we look forward to that conversation over what that might mean for Tennessee in improving healthcare.
And the last question, Mr. And thank you, Mr. Chairman, is when you referenced earlier metrics and milestones, what kind of, I will put that in the bucket of what I would term as outcomes. What are the outcomes that we should be looking for? And this is a year over year because this is done on a year to year basis. So year over year, what are the kind of metrics and outcomes we should be looking for?
Thank you for the question, Mr. Chairman. I attempted to name a few of those as we went along. Would be happy to share that component of the application with you and sit down and
thank you.
Share those with the committee.
Thank you.
Senator Crow.
Thank you. I think you mentioned a couple of things that are really, the center of attention for the health committees this year, CON and scope of practice. From a scope of practice perspective, there's been a lot of talk about what are we really trying to do. Are we trying to does the Trump administration want us to move toward independent practice? Is that what they're thinking, or as you said, Michael, to possibly make sure we have the different practitioners working at the top of their scope that we know? And I guess one of the problems from an independent practice perspective, we're not sure what the definition of independent practice would be as a state, or I'm not sure that the feds understand what independent practice means, for these different ones. And we've taken, kind of like CON, we've taken some steps. Senator Reeves, I think, had the bill for PAs to make sure we have practice guidelines for them, which was great. The nurses pulled out of that and didn't want any part of it. So, from the perspective of where we are with these different ones, I guess I like what you said about with CON. We've had 2 bills, I think, to try to phase that out and try to make for a better situation, for a competitive atmosphere, I guess, for the different areas in the state. And I voted for both of those. And I think what you were saying there is we want to build on that and try to go forward in a way that can work, but not hurt our areas out there. And I'm for that. And I guess the independent practice, how are we? Is that what we're shooting for, and how do we do that? I think like the PAs are more advanced in that direction of independent practice than the nurses would be at this time. Because we haven't done practice guidelines for them, and Anyway, you know what I mean? Where are we?
Thank you for that question. And just one point I want to make on policy is that this administration, the Trump administration, is looking to states to lead. This is an invitation, not a mandate. It's an invitation to work toward innovative, system-wide change for the health of each and every Tennessean for generations to come. So the program is designed to award and reward states to take action, and Tennessee our hope is for Tennessee to be one of those states. As it relates to scope, you are correct, sir, that whether we're talking MPs, PAs, pharmacists, dental hygienists, it does look different for each practice, for each skilled practitioner. And that's the approach we're trying to take. Again, we don't have draft legislation. We are working through that at this moment. So we'd be delighted to sit down and hear your thoughts on it.
Yeah, I think we should talk to different kinds of practitioners that are out there on the ground, nurse practitioners, physicians that work with them, to see how do we do that? And, in a way that we're moving in the right direction, but we're with you on that. We got to figure that out. How can we get them to the point that in the rural areas, if we do have a shortage of docs, that we can make that work, so that the Tennessee Medical Association and the Board of Nursing and everybody's working together for something that can work. But anyway, yeah, I guess we can move forward trying to make sure we do it in steps. Yeah. And I guess that's why the 5 or 6 years, right? We don't have to do it all at once. Say if we need, if we want to move nurse practitioners up in that regard, and from to an independent practice perspective, we might want to look at better curriculum in pharmacology and anatomy and physiology and biochemistry, and because right now the nurse practitioners are from a physician perspective are really practicing whatever the doc wants. You're doing whatever the doc wants them to do, and so it can be. I guess we just need to make sure that we're moving this in a way that provides for that kind of training they need before we do it. I mean, we can't just say all of a sudden you're going to be at this level. How do we move them logically to that? You know what I mean?
Thanks, sir.
Dr. Wu knows what I mean. You gotta. They don't have a residency program. Yeah. Anyway, okay.
Representative Faison.
Thank you, Mr. Chairman. Gentlemen, so glad that you are with us. Something that I've been passionate about for a while now, specifically because of rural Tennessee. And I've actually traveled abroad to study it. And before asking the question, I'll kind of set this up. It's kind of a stain on Tennessee, our addiction rate of substance abuse. I think the national average is around 15% addiction rate. Tennessee is above 18% addiction rate. I would say a lot of that 18% is found in rural Tennessee. Appalachia is rough. And my gut is sitting here talking to the chairman that there's something in this $200 million that you're going to do with substance abuse. And I was just hoping you would specifically share with the committee what your thoughts are, and do you need our thoughts to help you find out what to do for substance abuse in rural Tennessee? Thank you.
Thank you, sir. And if I could quickly invite our colleagues from the Department of Mental Health, Matt Yancey, they'll also be able to answer that question too.
Thank you, Chairman. As Matt's getting seated, I'm from rural East Tennessee and spent the early part of my career in Appalachia, and appreciate the concern there. Our hope is that those prevention dollars are an effective way for community-led solutions to continue addressing those substance abuse issues. We're starting to see some success, we think.
Good afternoon. Matt Yancey, Deputy Commissioner with the Tennessee Department of Mental Health and Substance Abuse Services. I'm honored to be here. Chairman Faison, I'm glad you asked about addiction. Obviously, that's something we as a department have been hyper-focused on since our beginning. We're really excited with the Rural Health Transformation Program because it's going to help us expand some initiatives that we've recently started that we think they're moving the needle on mental illness, on addiction and recovery. One of the things that we'll be doing with these funds is called Project Rural Recovery. Michael mentioned when the governor began his first executive order, as you know, was tasking all of us to think more about rural communities and what we could do. We took advantage of that and pursued a grant that has funded mobile healthcare clinics, mobile buses that are going to rural communities across the state to provide integrated care, including mental health and substance use treatment. We're looking to do that with this grant, go to other underserved rural communities with mobile health care. We know that there's not a community mental health center or substance abuse treatment center in every location across the state, but these buses are going to those communities. They're going there one day a week, setting up in the parking lots of Dollar Generals, of churches. And we've served thousands of people over the past 4 or 5 years in these clinics. It's increasing access, and we're having great outcomes. The other thing that we're going to do with these funds is really partner with the Department of Health and look at the local health departments. We know that that's where a lot of folks go to get their primary care. They should also be able to get mental health treatment, substance use treatment there as well. So we're going to be partnering with our existing provider network to co-locate mental health, substance use treatment professionals in those rural health departments to ensure they have access to those services. The other thing that we think is really important, and JW mentioned this as far as workforce development, across all of healthcare, we know there's acute shortages, is significant when it comes to behavioral health professionals. We're going to continue to invest in people in our state who want to advance their education in behavioral health related fields. And the commitment after our investments made is they have to commit to work with one of the agencies that we fund. And with these dollars, the focus will be working in those agencies in rural communities.
Thank you, Mr. Chair. Thank you for that. I would, I've never heard of these rural buses. That's exciting. I think the legislature would love to know more about what you just said. Studies indicate in Tennessee that there's an average of 11 people who will raise their hand today in Tennessee and say, I'm an addict, I need help. We have the capacity to help 4 of them today. We have the highest overdose rate of any state around us. If this is happening, what you're saying, everybody in this committee and the legislature needs to know about it. And if you call right now today, y'all's hotline, you and I both know you're not going to, it's rough. So with 210 million or 206 million coming, I would love to see if only 4 out of the 11 who raised their hand today who need to get help. Let's trim off of that 11. Let's take this serious. We as Republicans say we're pro-life, and I want to tell you, gentlemen, something. If we're pro-life, we're not just pro-life before birth. We're pro-life, and I could bring people in here who were addicts, who were on the streets, and somebody reached a hand to them and helped them, and now they're major positive role members in society. And it's incumbent on us to make sure we're using some of this rural health initiative to minister to these people.
Thank you. If we could, let's make our statements in the form of a question. That's okay. Chairman Yeager, and then Williams, then Camper.
Thank you, Mr. Chairman. I appreciate your letting me ask a few questions today. It's my understanding that the fees that are generated by the current certificates of need generate just a little bit south of $1 million, about $865,000 annually, and that is a good estimate. But obviously, if we do eliminate certificates of need, that's $1 million going away, which is, I believe, is used to support the Health Facilities Commission budget. So are you working your way through this issue with the Health Facilities Commission?
Thank you, sir. And we are indeed. They've been very cooperative and very helpful as we think through our options and what funding and support they might need. They've been very helpful. Those conversations are still ongoing, but yes, sir, we are.
All right, thank you. And Mr. Chairman, just my last question with regards to the Department of Mental Health. First of all, I want to thank you, the Commissioner, and all of you for an outstanding job that you do for Tennessee. And I had the opportunity to sit down with some of my behavioral health providers in the district just last week that serve all of the counties in my rural district. And we talked about having support in every county for problems in our schools. And I think we use the contract with our behavioral health groups to provide that. I learned from those meetings that we really don't have a person at every school. We have one for the particular county who would serve the schools for, and some of my counties may have 5 to 7, high schools, for example. Could these rural health dollars offer any improvement to this issue? Has that been discussed or looked at?
So for this particular grant, funds are not being used to support our school-based mental health. But what I will say, thanks to the legislature, thanks to the governor, we've been able to expand that program significantly over the past 5-6 years. We have almost 400 master's level clinicians working in schools across the state. We've talked about publicly, and our commissioners talked about the long-term goal of having a mental health clinician in every school. We know how important that is. But we really couldn't be where we are today without y'all's investments in that work. And as I've talked about, we're trying to be deliberate as we do that, because we know we've got to cultivate the workforce of people to work in the schools. And through the Pathways Scholarship that y'all have funded and through the provider rate increases y'all have invested in our department, more and more people are wanting to get into the behavioral health field. And a lot of those professionals want to work in the school environment. They see how important that is. So even though these funds won't support that at the moment, we have certainly been blessed with state dollars to help expand that work.
Thank you. And thank you, Mr. Chairman.
Representative Williams.
Thank you. Thank you, Chairman. I had a few questions too, and I apologize to the committee if it takes me a minute to get through them. But we're spending $206 million, so I think it's important. The questions regarding certificate of need obviously is something that this body has modified or changed over the last 12 years. I noticed that I think it's page 13 of the application, I think it is, where it talks about the repeal of certificate of need. The question was asked earlier, and I don't think I really heard an answer. What are the ramifications of that? So you got $100 million, you're getting $106 million of that is monies that we're doing based upon our transformational ideas. And so if this body didn't pass certificate of need, do you think that's going to be a $10 million loss, a $1 million loss, or $106 million loss?
Thank you for the question. At this moment, we do not have that official answer from CMS.
Was that based upon the Cicero Institute's study in 2024, where it ranked Tennessee as 85 points and 36th in the nation as it relates to CON? And do they take into consideration the same scoring system that you talked about in the conference call that you had with us in October, I believe it was?
You are correct that CMS, in their notice of funding opportunity, their NOFO, for each of the policy items that they're looking at, they show you where they receive their data. Mm-hmm. And for certificate of need, you're absolutely right. They're pulling from Cicero's report. Mm-hmm. It is, I believe, from 2024, as you said, mm-hmm. and was issued before the most recent reform passed for CON by this legislature. They were in the NOFO saying that they're using that, though, as their baseline mm-hmm. for ranking states.
Yeah. If you look at the Cicero report, unfortunately, I read it. We're 85 points based upon the reforms that we passed regarding CON. We're probably around 50 points, which drops us from 36 to 24th, I believe, in the category, which based upon the conversation we had back in October, the idea was that they wanted to see that over time that we were making change, and they would give us credit for that as we did that. So I'm hopeful that the ramifications wouldn't be $106 million if we choose not to do that. I will say that for someone who serves a rural area, the reason why we made the change that we did last time is because payer mix is everything. It's everything to a rural community. You can stand up a metropolitan hospital here today, and I can just about guarantee you that their private pay mix is higher than their public, and it's the exact opposite when you get to rural Tennessee. And so when I asked Dr. Wu about reimbursement rates and how we're providing for providers in rural areas, that's transformational. I would agree with Senator Watson that there's not a whole lot that's transformational about this. It looks like a retitling in some areas. And I think it's really important for us to know that the reason why we moved to licensure and payer mix is because it is the last best best effort for us to provide some kind of protection for those small rural hospitals, of which 75% have disappeared under this administration. So it's really difficult to hear that we would tie any funding to a commitment that we've worked so hard over the last 12 years to do. I did notice on page 42 of the application, it also gives a list of the members that will serve on the committee. In that list, it gives all the administration titles of those people who expect to serve on the committee once it's stood up. There is a reference to a legislative leadership team. I know with FSAG, this body, the Tennessee General Assembly, represented what we call a 2/5 majority of the voting group in FSAG. If that legislative team is 2, it's completely different, which I guess 2 questions. How many people do you think would serve from this body on this committee? And have you communicated with any legislative leadership as it relates to input, as it relates to the submission of this application? Because quite frankly, some of it is kind of a surprise to me.
Thank you for the question, Chairman. We have not set up the first meeting of the governance committee, which we expect to happen later in the spring.
Mm-hmm.
And so those conversations are ongoing. I think we'd be open to input from membership.
Yeah, and my suggestion would be that it would be not a majority of legislators, but it would be legislators in the health field who have served here. I think the reason why that's important to me is because even though you are doing a phenomenal job, there's the clock's ticking, as they say in Top Gun. You got a little red light blinking in the corner of your eye. You're not going to be here at the end of this, and it's going to be the legislative body that sits here that's approving out years as it relates to this spending and funding. And so I think it's important that they play an integral role in the decision-making process going forward. Just a couple of things, Chairman. Based upon my review of what the different tranches of money and the 16 or 17 different pools of money you've set aside in the application, I referenced the Health Information Exchange earlier, how we had 24 positions there. It looks as if, in rough math, and the speaker asked me to do rough math all the time, and it's not fun, but it looks to me like about 30% of this $206 million could be construed one way or the other as recurring revenue. The purpose of this committee is to ensure that these federal dollars and the dangling carrot is not going to inhibit us or future legislatures as it relates to the spend. What do you believe is the dollar number associated with what could in fact be recurring revenue 6 years from today?
Thank you for the question, Chairman, and the feedback. I don't think that we have a suggestion as to what would be recurring, other than that we wanted to make sure that any program leader is thinking about evaluating what works before we've begun, that at the end of 1 year or 5 years, we're able to demonstrate meaningful impact and a meaningful return on investment.
Mm-hmm.
And it would be up to the will of the legislature, of course, to decide if any of that was to move to state funding.
Mm-hmm.
But we did explicitly challenge each of them to think about, this is a limited opportunity.
Mm-hmm.
We do not want to create cliffs. What is going to be your pathway to sustainability with the assumption that this program is having the intended impact?
Right. So in the example that was given earlier, we have a consultant that we're talking to about Health Information Exchange. We think we have somebody that we want to talk to. Obviously, we got to put our RFP out there, but in standing up a Health Information Exchange at $15 million for the first year, are we going to see that $15 million recurring in year 6? That's the kind of questions that we need to know. It could be $3 million. I don't know what the answer to that is, but hopefully the reason for this committee is that we're asking you those questions, because to come up with $206 million recurring 6 years from now is going to be a lot more difficult than it is today. Doctor.
Oh, I am on, sorry. Yeah, Chairman Williams, great question, great point. We understand that state's under no obligation to fund this long-term. As JW said, we're trying to build it that way. You mentioned HIE. We don't anticipate state dollars funding that in the future. And that's going to be part of our consultant work to ensure that we're not putting the state on the hook for something long-term in that particular instance. And we can go item by item as we need to and talk about what the long-term ramifications will be.
Okay, thank you. I look forward to getting that information from you.
Yes, sir.
Chairman, three more questions. Tennessee, Dr. Wu, Tennessee Community Compass portion of the program. Do we not already do this in TennCare on your website currently? And why can we not easily fold Department of Health into it if that's the only person left to do?
Thanks for the question, Representative Williams. It's a good one. We have certainly made a lot of progress on Tennessee Community Compass and are seeing great success. The one area that I would say that there's a lot of opportunity, though, is as with everything on Community Compass, the more resources that are readily available for individuals and communities, hospital systems, provider communities to access, the better it is. And so what in our proposal we described was actually 3 agencies, all of which are very excited about putting their programs on to make a seamless one-stop opportunity to do that. That would include DDA, DHS, and TDH. So all 3 of those agencies have already been thinking about this work and building on, and I think taking advantage of the scaffolding, the efficiencies, and the speed with which they could build on top of Tennessee Community Compass and at a much lower cost.
Okay. One other question about substance abuse, and this goes for all of it. What we have found, love what's going on at the federal level right now, but what we have found is that by the stroke of a pen, someone can eliminate something pretty fast. Matter of fact, today, the Trump administration scratched all grants as it relates to mental health and substance abuse. Does that mean the monies that we set aside in this ask are now gone?
Representative Williams, we were also apprised of that last night. We're still putting the facts together, but as I understand, it wouldn't have any implications on this grant and the funds set aside for behavioral health.
Would it in years 2 through 5?
I can't speak to that.
Just add, as far as we know, this is a separate pot of money from the guidance that was issued last night.
Okay. So that begs the question, if the Trump administration chooses to unilaterally strike any component that we cannot use, can we move money from one component of the 17 things to another, or is it gone?
Chairman, we'll have an opportunity on an annual basis to make adjustments to our budget.
Okay. I think that's all, Chairman. Thank you.
Representative Camper and then Senator Lamar. So Representative Camper.
Thank you, Mr. Chairman. Could you go to your slide on the uses, that slide? Thank you. That last bullet point there, fostering collaborations, which is something that I feel the urban metro hospitals have been doing because the Affordable Care Act in this state was not fully implemented. Medicaid was not expanded. People had longer times to get to a hospital. Hospitals closed disproportionately in those rural areas. So we were collaborating, and we stand poised to collaborate now. Secondly, the line above it says capital expenditures and infrastructure. That's the area I'm talking about. You were saying your vision was that these hospitals that closed because we did not expand Medicaid, you have the ability to do some capital work, to work on the infrastructure, to stand these hospitals back up. Is that true?
CMS has provided additional information on this through the FAQ process after the NOFO was released, and basically said if it involves permitting, we can't fund it through this grant. So including things like playgrounds, minor building adjustments are allowable. That's the extent of it. And they've been pretty, they've continued to constrict that definition.
I understand.
Yes, ma'am.
So we stand ready to continue to collaborate with you.
Thank
And
you.
in that collaboration, the question was, would we be able to get funding for that collaboration? And I think you said yes.
We obviously will defer to the will of the General Assembly here and the guidance from CMS, which was not particularly prescriptive. I do appreciate where you're coming from. The collaboration piece is something that we have loved seeing in our rural communities with our county health councils who bring these types of partners to the table and provide different areas of expertise that build on each other in each of our communities. Each program is written because of the expectations of CMS is to impact rural populations, and that's certainly our intent through this program.
Thank you, Mr. Chairman. Thank you for your answer.
Senator Lamar.
Thank you, Mr. Chair. My next question, piggybacking off the sentiments of Chairman Faison, according to the CDC, Tennessee has the highest maternal mortality rate in the country, meaning more women in our state die than any other state in the country. And what we do know is based on that, over half, if not more, of these women are on tent care. And outside of Shelby, many of these women are in the rural areas as well. And so in addition to my strong belief that adding doula services as a service under tent care will help mitigate this problem because it's been very transformational and successful in other red states across this country, we do know that maternal wards in our rural areas have closed down because of hospital closures. Is there a plan of action with these funds, in addition to my belief around doula services, to either fund new maternal wards, reopen closed maternal wards, or create new maternal wards or healthcare facilities so that some of the women in the rural areas who are having to travel 30 minutes, an hour and a half to the nearest hospital can access care quicker?
Thank you very much for the question, Senator. We shared those statistics widely internally. It was a sad thing for us to see for our state. There was a lot of consensus between all the partners at the table that maternal and child health was going to be an important part of this application early on. And so you'll see multiple opportunities to expand maternity care access, including in our service expansion work, which could, for instance, including OB lines where they're currently unavailable, as well as within the competitive maternal and child health programs where entities could apply for any types of services that showed us that they were having an impact on maternal and infant health outcomes. Additionally, there will be investments made for EMS staff to be better trained in perinatal care, so that someone gave the example of a woman who might live in Lake County in rural West Tennessee, not needing to go to a large center in Memphis, but to receive services closer to home. And that's the goal for all Tennesseans. Is that they get that better care closer to home. Yeah. Thank you, ma'am.
One question I have, does CMS provide for an opportunity to revise the plan as adjustments are needed?
Thank you, Chairman. Yes, sir. On an annual basis, we'll have an opportunity to revise our plan based on what we see is working and having an impact. We'll receive additional guidance on what flexibility we may have with monthly meetings with our project officers with CMS, which are yet to be initiated. Thank you.
Thank you. Chairman Watson.
Thank you, Mr. Chairman, for your indulgence. A couple of things. First of all, just to respond to a question that our caucus, Republican caucus chair in the Senate asked about CON and cost impact on healthcare facilities. Well, one thing is you would reduce the administrative cost because there would be less regulatory burden along the lines for the agency. And the second is, as been discussed a number of times throughout all of our different CON reform efforts, you move away from a CON-driven kind of system to a licensure-driven system. And so much of those fee losses that may be part of a narrative, those fee losses actually can be absorbed into the licensure. So there's actually probably savings to the state by eliminating the Certificate of Need program. To the next point, I do have some, and I know I think you addressed this or talk about this, at least in the application, on the sustainability. And to at least my Republican colleagues, I'll remind you of a quote from Ronald Reagan in October. And there is a question here, Mr. Chairman. So I'm going to, a quote from Ronald Reagan in 1964, "No government ever voluntarily reduces itself in size. Government programs once launched never disappear. Actually, a government bureau is the nearest thing to eternal life we will ever see on this earth." And I say that and we laugh about it, but we have just witnessed that play out. So back earlier at the end of last year in the fall, we saw the government shut down over a temporary health payment supplement. Okay, the government shut down over a temporary. Everybody who voted for that 3 years ago acknowledged that this was a temporary supplement until it had to be renewed. Then all of a sudden, it wasn't temporary, it needed to be permanent. My concern with, at the end of 5 years and $1 billion expended, and the federal government no longer having that $1 billion, and by the way, to my colleagues, we are facing that in some educational spaces now, as some of the money that we've used for good educational purposes, those federal dollars are no longer there, and the state's going to have to decide, are we going to appropriate dollars for that, or are we going to let the program go away? As we have witnessed, particularly around healthcare, it is not easy after 5 years to just say, you know what, we don't have the money anymore, we're not going to do this anymore. And so I wanted to ask, so I do have a question, Mr. Chairman. I do want to ask, is there within every year, do we have the opportunity to say, you know what, we're done? We've done this for, let's just say hypothetically, we've done this for 2 years. We don't see any progress. We've seen nothing transformational. We're done. Can we make that decision?
Thank you, Mr. Chairman. Yes.
Okay, thank you.
Yep. Chairman Crow.
Michael, just to follow up very briefly, because we're through here, I think, on the scope of practice for mid-level nurses. I forgot to tell you that the other day, a team from the East Tennessee State University Center for the Advancement of Nursing that we put together as a legislature several years ago, they're doing lots of work right now on that. And I'll have Daniel in my office send you the contact, okay? Because they're doing lots of work on that, and they're not trying to do independent practice. They're not trying to do, they're trying to move in the direction that they think we should to get to the top of the scope, you know, for a mid-level nurse that works for everybody. And so they're really good at that. That's what they're doing right now. So I'll get you that. Yeah.
Thank you, sir.
Thank you for your presentation. Members, we have, we're on discussion now. Yes, we're discussion and we're not ready to adjourn, but we have questions been put.
Is it, I just didn't know. So tell me, does the body have the ability to make a motion to adopt in full or in part, or how does that work?
Yeah, no, I think our authority is to accept approval of the, to approve acceptance of the grant or to disapprove acceptance of the grant.
Thank you.
So we'll entertain a motion unless there's discussion. Yep, you're recognized.
Thank you, Mr. Chairman. When we move to accept the grant, are we accepting just to allow them to accept the grant, the dollar amount, or when we say accept the grant, are we agreeing to all of the terms they have heard discussed today? Because there's, for example, I may have some more questions about the certificates of need, but I want to work with them and keep us moving. But so I would assume that, just stay with that example, that there would be legislation filed that would take care of it. Am I wrong in thinking that, or? We're moving forward to allow them to accept the money.
A plan has been submitted to CMS.
Yes, sir.
The plan generated $207 million.
Yes.
In the first, under that plan. If parts of the legislation, in my understanding, let's say part of that plan requires legislation in order to receive the full amount or keep the full amount. Let's say we don't pass CON.
All right.
My understanding.
Sure.
Perhaps in the next year, this was asked and answered, Perhaps in the next year, there could be less money
All right, yes, I
available
recall that.
in the next round of funding.
All right, thank you for, I appreciate that clarity.
And
of
so,
answer.
and again, to my question was, we can adjust the plan. I mean, frankly, we didn't have a lot of input as a General Assembly in the creation of this plan. We're simply tasked right now with accepting a plan that was presented today with very limited input from the General Assembly. And it generated, to your credit, it generated in excess of the minimal basis. I mean, 100 million plus another 100 million, we got an extra roughly 7. So, but we look forward to having our own input into future out years in the General Assembly's input in out years as we see where these dollars have been spent, how they've been spent, what progress has been made towards the goals set through the act or the program itself. And so I think the purpose of today is the acceptance of the 207, little less than 207, pursuant to the plan that's been submitted, which we have thoroughly, I think, vetted to the degree we could today. And so with that, I'll entertain a motion. We have a motion to accept approval of the grant. It's been properly seconded. Discussion? I see none. We'll take a vote of the Senate first and the House as the custom for a joint committee. Madam Clerk, take the vote of the Senate.
Senator Johnson? Votes aye. Senator Lamar? Votes aye. Senator Watson? Votes aye. Senator Yeager? Votes aye. Chairman Stevens?
Aye.
Votes aye. Mr. Chairman, you have 5 ayes in the Senate.
5 ayes in the Senate. Madam Clerk, take the vote of the House.
Representative Camper? Votes aye. Representative Faison? Votes aye. Representative Garrett? Votes aye. Representative Miller? Votes aye. Representative Moody?
Aye.
Votes aye. Representative Sparks? Votes aye. Representative Williams? Votes aye. Representative Zachary? Votes aye. Chairman Halsey? You have 9 ayes.
Thank you, Madam Clerk. The vote is unanimous of the House and Senate to accept the grant. With that, we'll entertain a motion to adjourn. So moved. We are adjourned.
Thank you.